Thank you, Keith. I'm going to just build on the last point you made. You gave us a short list of things that we could rally around, and I'm going to ask our panel for another idea to add to the list of some things that we could rally around that would help this dilemma, help solve this dilemma, not this problem, or help improve this dilemma. So let me start with you, Bob.
I'm always intrigued when I hear a payer say we don't have enough evidence to cover non-pharmacologic therapies. Because from my perspective, when I look at every therapy that we have for pain, we have the same kind of evidence. We have low to moderate quality evidence that it makes a moderate degree of difference over the short term. It used to be that when I would say to a payer, why aren't you covering chiropractic, acupuncture, massage, yada, 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 I would get, well, we don't have enough evidence. And my response would be, well, you cover long-term opioid therapy, don't you? What kind of evidence do you have for that? And I would get a shrug. But I think it's a little disingenuous at this point, especially now that we have a 450-page report from the AHRQ that says that certain non-pharmacologic therapies work for certain types of chronic pain. And I think we're going to have to get past the point of saying we have to have perfect evidence for everything before we decide to cover it, because if we wait for the evidence, we're never going to cover anything. And we shouldn't be covering anything that we're doing now, because it's all the same kind of evidence. So my request is that we all push on on the payers to say, what more do you want? How do you expect us to get the kind of evidence that you want? Maybe you can help us get the evidence that you want. Maybe there's some ways that you can help us set up demonstration projects to show you that this stuff actually works. So I think we've got to ramp up the volume to the payers to say, hey guys, we really do need to have these other treatments, because otherwise we're going to keep doing what we've always done. We're going to keep acting like we have one tool to treat pain. And that tool is a hammer that we call opioids, which is why everybody's walking around hammered on opioids these days. We have to have access to the other tools in the toolbox. And until we get the access to those tools, and until we have enough training to understand how to use those tools appropriately, and understand how to assess a patient to figure out which tools are going to work for them, we're just going to be spinning in circles, I'm afraid.
Jessica, add one thing to the list.
I've mentioned this briefly before, but I think helping to educate both providers as well as patients on what risk looks like and what risk factors truly are, better history taking, can help sort of self-identify our own behaviors, prevent addiction from developing in the first place, and I think have some better tools in that toolbox. That not everyone has the same risk level, and I think we don't, when I go in for a doctor's appointment, they ask for the history in my family for heart disease or cancer. What about the history in my family for substance use disorder or alcohol use disorder? What about my own particular characteristics or risk factors that I bring to the table that maybe Bob doesn't, so that when you are prescribing me medications that I need, we understand what my risk profile truly looks like. And I think that's not just for necessarily this one patient population, that's really for everyone. And I think that we don't have all the evidence or science that we need on this component. We have a lot of it, and we just need to put it into practice and do a better job of having a sort of a team approach to understanding how this disease really develops in the first place.
Dan, one thing to add to the list. Just one. Beyond training.
Yeah, back to the point of education and the lack of departments and specialists who are in academia to train the medical students and residents and faculty. I think there needs to be some investment in faculty development, because we're not going to have enough, board-certified pain specialists and addiction specialists to satisfy the needs for all of the various academic centers that are training the next cadre of doctors and other health professionals, PAs, NPs, nurses, and so forth. So I think we need to come up with some multidisciplinary faculty development program to get folks who can do that training soon, as opposed to waiting long term. And connected with that is that there's a lot of educational content out there, and it's overwhelming even to me. And so if there was some central clearinghouse of all of the educational materials in a way that could be easily identified and used for whatever purposes you need them for. But, the CDC has stuff, the FDA REMS program, the AMA, the ACP, you name it, every specialty society. So if there was some way to just have an easy clearinghouse for that information.
Patrice?
And I'm not saying that the AMA needs to be that clearinghouse, but actually on our opioid epidemic microsite, we do have a clearinghouse of all the information that our states and specialties have submitted to us. And so if you go on that link and then you're a physician in Pennsylvania and you're a psychiatrist, you can look up resources for your specialty in your state. So we have that, and I think you're right. And maybe there shouldn't be just one, but folks should know, here's where you can go. You can try this microsite, you can go to SAMHSA. So I agree that there should be some information available regarding the repository of information. So in addition to eliminating barriers to non-opioid pain care, I would like to add to the list elimination of barriers to medication-assisted treatment.
Okay.
We know that when a person decides, perhaps in the ED after an overdose, that they want treatment, there should not be a barrier to them getting access to that treatment. And so we want to make sure we there are no prior approvals for those who have insurance. And for those who are in the public system, we have to make sure that there's appropriate reimbursement for those who choose to offer that care.
And I would just add, as we've done, no copays for methadone and other interventions.
Yes,
How's that?
That's part of the whole payment policy,
Right.
so we can lump that all into to one.
So Keith, you started this, and you're going to get to end. You already had your list, but perhaps you had one more item that...
Sure. One more thing. So we just passed this huge opioid support act, and I spent a lot of time with people in the House and the Senate on that bill, and I was very impressed how many people cared genuinely and how they were trying to do the right thing. And so but I want to say something critical of the bill despite that, which is it's still thinking about addiction as a crisis. A crisis meaning if we work hard on it for a couple of years, we'll resolve it, and then there won't be any more addiction. And how we have to think about it as this is just a core feature of human health. There has never been a time in the United States where there were not addicted people. There's never been a time when it didn't kill many people and disable many people. So it's not going to be solved by a 2-year grant to the states. It has to be built into the structure of medicine. And you do that in the American system by building it into the financing of medicine. And what that means is to concretely going into CMS, going into Medicaid and Medicare, and permanently changing the reimbursements so that it is a well-reimbursed condition like cancer, like heart disease, so that medicine is always equipped to take care of it, because it's always going to be there. It's always going to be part of what you do as a doctor or a nurse or a psychologist or whatever. So we need to get out of that crisis mentality.
Thanks. So we have long lines at both mics, so a lot of people want to get in. I'll ask first, as has been the convention today, whether we have a question from our online audience.
Good afternoon. We do have a question from Twitter, and I do want to just let you know, for those of you who are not monitoring Twitter this afternoon, we have quite a number of pain patients who are online and expressing their desire and interest in the topic, and their interest in wanting to be here, but because of their condition cannot be here in person. So they thank everyone for participating today, but also really strongly want their voices to continue to be heard. And so this question is from a woman identified as Average Chick, and she is a patient with ankylosing spondylitis, an extremely painful condition, and represents herself and way too many people who are suffering every day. And her question is, are you aware that in many places where medical CBD and medical marijuana are legal, that pain management will still kick you out if it's found in your urinalysis? Can the discussion today lead to advocacy for changes such as this and others? We need your help. We are suffering every day.
Thank you. And what I'm going to do is, because we have such a large panel and we're not going to be able to all answer all the questions because we won't get to all the questioners, I'll throw that one to you, Bob.
I think the whole issue of marijuana and CBD in particular is a challenge. I've been pushed on behalf of my organization for the past couple of years to come up with a position statement, and I just can't yet because I don't think the state of the science is such that we're able to do that. And having been burned by the opioid problem, I'm afraid to jump in and say I'm all for medical marijuana, only to find out 10 years from now we have a huge problem with marijuana addiction. So it is a really challenging problem, and I think we need to continue to figure out how this works for people, for whom it works, why and how it works, and how best to deliver the care. And I know there's some people doing some great work on that, but it is just still a challenge for me to be able to come to grips with it.
Thanks. Question over here, ma'am.
My name is Ann Fuquay, and I'm with the Alliance for the Treatment of Intractable Pain. I've been on approximately 1,000 MME for over a decade and have had obvious benefit without any side effects. I can't begin to tell you how much my quality of life and ability to be independent has improved. Doses like mine aren't appropriate in most cases. Most of the ultra-high dose patients like me have not been nearly as fortunate. Even most patients who have genuinely benefited have been tapered as a result of the push to reduce opioid prescribing. Tapering has even the patients who truly benefited from the higher doses have been tapered beyond what they can tolerate, to the extent that their quality of life is almost non-existent. Getting out to come to a meeting like this would be impossible for them. In 2015, my doctor, who I'd seen for 9 years, closed his pain management practice. What followed was the worst experience of my entire life. I've been incredibly blessed and able to return to my previous dose. 3 years, though, and I'm still not back to normal. Pain, not withdrawal, caused my blood pressure to elevate to stroke levels. This was despite large amounts of clonidine and nitroglycerin. I now have significant short-term memory deficits documented through neuropsych testing. I often do things that remind me of my grandmother when she was early in the course of vascular dementia. I chose to stop driving. I definitely do not live in a city with the mass transit resources of Washington, D.C. But I'm incredibly grateful for the life that I have because it requires a 4,000-mile round trip every 3 months. The trip from Alabama to California is brutal, and the associated expense has been a huge financial burden. My question: how do we enable healthcare providers to be pro-patient and ensure long-term patients who are stable on high doses continue to have access to those medications?
Thank you for that question. Who would like to take it? Patrice or Dan?
Thank you for your comments, and I think you represent the issue of individualized care and the importance of individualized care. I think most people might look at a high dose and say, wow, how can anyone function on that dose? You can, and so we have to look at patients, not dosages. So thank you for sharing that story, and the AMA has been steadfast in our commitment regarding decisions regarding to treat or not to treat and how much should be between the patient and their physician. But I think we learned earlier that there are all these other external disincentives to do so. I think your question about will prescribing go down if there's a threat of the DEA coming, absolutely. And so we have to do whatever we can to make sure people are aware that the threats, worrying about the letter you saw in the AJC and the doctors with the high prescribing getting a letter and how that will impact your patients. Remember, as a physician, my license and my ability to practice is my livelihood. If I can't do that, what am I to do? And as the child psychiatrist, I should make sure that I continue to do that. So I can tell you that at the AMA, we will continue to advocate with the pro-patient. And doctors, you're right, should not have to be afraid.
Thank you, Patrice. And I would just add, Dan made the point that we need more team-based care, which I wish we had gotten to. And if I could extrapolate from what Jessica said, patients have to be part of the team. It's not just clinicians, it's the patients and the families in this case. Over here, Stefan.
Stefan Friedrichsdorf, pediatrician and pediatric pain specialist in palliative care, and you know what's coming now. So, Our topic today is pain and symptom management for people with serious illness, right? And so that means children and adults. And so, so far, and thank you, was it Jessica? Yeah, Jessica to covering peds and it's covering it. But we haven't talked a lot about children yet. And this is the final session and this learning to inform policy and practice. So I think my question is, to advocate for children, for 25% of our population, where do you see this going? So how can you help? How can the AMA help? How can others help those kids who have a much quieter voice in addressing acute and chronic pain? Because it's really not just adults, it's adult and children. So where are the kids here? What can you do within your organizations to help children?
Jessica, is your advocacy group considering the needs and issues of kids?
Absolutely.
Okay, so why don't you talk about that?
You know, sort of front and center to make sure that you're addressing the needs when the need arises, whether that's a child or sort of pain issues in pediatrics or the development of a substance use disorder or early indicators of risky use or, you know, again, we don't typically begin developing an addiction with medications. This begins in alcohol, tobacco, and marijuana use. However, if we don't have proper voices for children and adolescents who are struggling with this, then we can't really solve the crisis. And I agree with the piece about this not being crisis focused. This is a healthcare issue that needs to be sort of embedded within our healthcare system. So we need to focus on prevention. We need to focus on making sure that we're providing individualized care. But the one thing that's important is that's for both sides of the coin. Individualized care for those that are struggling with pain and individualized care for patients that are struggling with substance use disorders. And so it's a big part of what we do, both on the provider side as well as families, communities, those that have more risk factors, children with adverse childhood experiences, early childhood trauma, high levels of risk factors. And I think so much of this is focused on adult populations, but it's not when this begins. So it's our pediatricians that are probably one of the most important players to be having with us at the table to figure out what the solutions look like.
But we're not usually on the table.
Well, we should change that.
Patrice, did you want to add to that?
Yeah.
Yes, as you heard, I chair the AMA's opioid task force, and while there are some certain links, of course, to pain, we have just begun work of a pain task force. And I will say that we will certainly be addressing the pediatric population in the pain task force, but also the American Academy of Pediatrics are represented on our opioid task force. So there's something that we think about.
Thanks, Jessica. And by the way, Stefan, in our plan in Massachusetts, we're in the middle schools working on prevention because, to Jessica's point, that's one of the places you need to be. So, question from Twitter? In back? No? Okay, over here.
Hello? Okay. Good afternoon. My name is Benita Talati. I'm here for two reasons. One, in my capacity, I am a contract attorney working on the opioid litigation against the pharmaceutical companies. But I'm here asking a question in my capacity as a patient. I'm also a patient living with Ehlers-Danlos syndrome. The question I have is this: how is serious illness defined? Because from what I've been hearing all day today, it's been all about palliative care and cancer pain. There are millions of people on Twitter right now, on Facebook, et cetera, listening to all of this. And they're all asking the same question. What about us? What about all of us who live with chronic pain, but not cancer, not palliative care? Those patients have also lost access to their meds. And then there are patients like me who we haven't even been offered opioids, even though, frankly, it's the next step in treatment or surgery because of the disparities in treatment that we've discussed today. So really, does serious illness also include rarely diagnosed diseases like mine or rare diseases, or is it only cancer and palliative care?
Bob?
You know, I think the core issue is suffering. And where people are suffering with pain, that's a serious illness in my book. And I think, you know, part of it too comes down to how you as an individual define it. If it's serious for you, then it needs to be serious for me as a provider. So I think it really is an issue of, is this something that is really causing some suffering, causing some decreased functioning, causing whatever issues? And if so, then it needs to be addressed, and it needs to be part of the picture. And it shouldn't be only cancer and other serious illnesses, life-limiting illnesses.
Well, that's the problem, because if there's no definition of it, there's issues of accessibility with insurance. Will insurance cover this? Will insurance cover that? That's part of the problem. We need to have a clear definition of what is a serious illness.
Thanks. And I will say that having participated on probably a dozen planning committee calls, we discussed this extensively, and this has actually been a larger issue for this roundtable. And I think there was a broad recognition that there are millions of patients struggling with chronic illness, with chronic pain, and with a variety of serious diseases and illnesses who are being affected by this kind of clash between trying to respond to an opioid epidemic on the one hand and trying to manage pain. So that was heavily discussed and will continue to be part of our thinking. So now I'm going to go over here.
Thank you so much.
Thank you.
I'm Heather Wargo. I'm a incurable painful disease patient advocate, and before, because I was so hurried, I didn't get to finish, and I also am an incurable painful disease patient. I'm a high-dose patient, and I have pancreatic disease and biliary disease. So I am here under the power of high-dose opioids. Wouldn't be here if it wasn't for my medication. So I thank God for my doctor and my pharmacist, and we are a team together, and I really do thank God for them every day. And I just want to add that I have a 4 to 5 pain level with my medication. I don't think any patient ever expects to be at a 0. I mean, at least chronic pain patients don't. Not the ones that I talk to anyway. So when I hear the stories about providers thinking that patients expect to be at a 0, that's not my experience with the patients I speak to. I just want you to know that that's not any of the expectations of the patients that I ever talk to. So I would not expect that patients think that, at least chronic pain patients. And the stats that I heard, 72,000 opioid-related deaths in 2017. Opioid-related deaths, that is largely due to fentanyl. The prescribed opioid deaths in 2017 were actually reduced by 16% from 2016. So prescribed opioid deaths actually dropped, which is a good thing. Sadly, the fentanyl is what's driving the deaths now, not prescribed opioids. So another study came out, SAMHSA said that over 80% of the people that are addicted to opioids are actually not even patients. They're people that get them for free from someone else or someone that stole prescribed opioids from someone else. So over 80% of the people that are actually addicted to opioids aren't even patients. They're people getting them from someone else. So under, 20% are patients. So we need to look at maybe education, I think, of providers getting people to lock up their medication, especially the short-term prescriptions, where I think is where most of the opioids are getting out and into people's hands. I think most chronic pain patients do lock up their meds. I think more of the short-term prescriptions may be getting sold or taken by a family member. And that's just what I want you to think about.
Great. Thank you very much. Over here. And why don't you raise your hand and back if there's a Twitter. Oh, you will? Okay, great. Thanks.
Thanks. I'm Jane Leipschus. I'm a general internist and addiction medicine physician, preventive medicine physician. I have an observation and a suggestion and a question. So the observation is that people who have chronic pain or addiction live with it 24/7, but they're in the doctor's office for 20 minutes, half hour, maybe an hour if they have a really long visit. So the vast majority of their lives are spent not in four walls of a medical setting, but out in the community. And when we think of solutions, they really need to integrate community with the patient's lives. In the same way you think about diabetes, people have to control their diet, whatever. We have to figure out how to bring in community into the solution. And then I am thinking about solutions, and one is thinking about tech. And no one has really brought that up today, but people are connected. I mean, how many people is there anybody in this room who does not have a smartphone? Right. So are there ways that we can take advantage of 21st century technology to connect, to help people, to make people part of solutions? I know there are things that going on, related to that, but I just want to throw that out, wondering about the panelists and some ideas. We're trying some things in our camp around, using technology, but I do think we could take advantage of today's society in helping people with pain.
Thanks, Jane. Yes, Keith.
That's a great point. Thank you for that. I tell you something from a study of in-person peer help, which is self-help groups. I've been very interested in groups like Alcoholics Anonymous and Narcotics Anonymous in my career. And one of the things I studied was what happens when a hospital really makes a big effort while people are in the inpatient part of treatment to link to those groups. It's very interesting. In the year after treatment, they use far less mental health services, but their health is far better. And you say, now, how can that be? I mean, and a reason is that a lot of healthcare utilization is surplus utilization. In other words, it's people come in because, they're sick, but also people come in because they're lonely, they're discouraged, they need a pat on the back, they just need some acknowledgement of their humanity. And you don't need an MD to provide all those things. Everybody needs them, I need them, we all do. But that we all have the capacity to give those things to each other. And that's what, the beauty, I think, of those fellowships is. That's done there, and then when you see a doctor, you really need to see that doctor. So you can take that point and extend it out to the power of these electronic networks. It's a huge amount of what a lot of people need. I need not to be alone in this. I need to know that someone's listening to me. I need to also be accountable. Someone will care if I go out and I use drugs again. People will react to that. I'm a person in a network, and so I think we should exploit it. And I also think, frankly, the people who have pain and addiction are exploiting already. They've already figured this out, and they're doing it like mad, and I salute them. Yeah.
Thanks, Keith. And we haven't really talked about the role of recovery coaches, but it's a related thing, and I'm sure, Jane, you're working on that, but that's going to be a big part, I think, of the future treatment system, and I think health plans and others presumably should be paying for that kind of service. Amy.
Thank you. I just want to comment that the day was really quite incredible, and your panel was just exceptional. So thank you for everything that you're doing. Patrice, you said physicians should not be afraid. And I would say that patients should not be afraid. My name is Amy Berman. I'm a program officer at the John A. Hartford Foundation in New York, a national foundation dedicated to improving the care of older adults, and one of the supporters of the Roundtable. I was diagnosed 8 years ago with stage 4 cancer that continues. I don't live in remission. I have never taken an opioid to this day, 8 years into it. I've been very fortunate, but I will be taking an opioid, I am quite sure, at one point. And statistically speaking, 11 to 20% survival to 5 years, that's what I was living with when I was initially diagnosed. So I would guess that sometime within the next year that might start to happen. We had an interesting conversation at lunch, somebody sharing that oftentimes they need to prescribe multiple times to get it right. The first prescription may cause nausea, the second may overly sedate, and so it wouldn't be unreasonable for people with a serious illness to end up having 3 prescriptions in a month. Given the blunt tools that plans and others are using, they're being caught, and they're being chastised. They're being unceremoniously dropped by pharmacies and others, and people are tapered needlessly, while trying to get the medications right in a whole host of illnesses. And by the way, I agree, this is beyond serious illness. This is about suffering broadly. So what would you say, what are the ways that we need to lessen the blunt instruments that we see out there and begin to address them and have white knights appear that are going to provide greater balance for us?
Patrice, it looked like that was directed to you.
Thank you. I would say do exactly as you just did, share your story. At the AMA, we are collecting these stories. We have asked physicians and patients to send us these stories of where they have been ceremoniously dumped or unceremoniously dumped at pharmacies. Today, when I heard Aura this morning of someone screaming at her, that makes me angry as a human, let alone a physician. So it's elevating these stories and sharing these stories, talking to you and sharing these stories with your state insurance commissioner. At the state level, insurance is regulated by state insurance commissioners, and they need to hear these stories when there are these egregious examples of what I believe are unacceptable behavior. So I would say share your stories. Again, at the AMA, we are collecting the stories. The letters that you saw earlier, we're asking physicians to send us copies of those letters so that we can go back and continue to advocate again on the state level and at the federal level if we need to, and with the payers and the pharmacies that are engaging in this behavior.
Amy, it's an important question because we have multiple panelists who want to respond. So Bob and then Dan.
You talk about the need to have multiple prescriptions in order to get it right. That happens. And the problems that it can cause, some of those problems would be relieved if we were allowed to do partial fills on some of these medications. Now, one of the things that's always perplexed me is that the CARA legislation, which I think passed 2 years ago, directed DEA to write regulations to allow for partial fills, and it still hasn't happened, despite multiple letters from the sponsors of the legislation to figure out why it's not happening. So I think that's, it's one little tiny piece of the solution, but, to do the things that we've already said we're going to do would be helpful in this case.
Dan?
Yeah,
And
thank
then
you for bringing
Jessica.
up. Thank you for bringing up that issue because it really is an important one, and that is about trying new medications and trying new medications that require prior authorization makes it very, very difficult for patients when they go to the pharmacy and they're told can't get that because you need prior authorization. Because, oftentimes we are trying something new and we don't know whether it's going to work. I'd like to do a partial fill, but I'd also like to have no gap between that medication that maybe didn't work and another medication that I'd like to try, namely around opioid rotation, again, to try to minimize escalating the dose to these mega doses in order to try to get effect, to switch to a different opioid. And it gets very complicated for the patient when they go to the pharmacy and are told, we can't get it, and they go days without a medication and go through withdrawal and everything else. So thank you for bringing that up.
Jessica, did you have a comment as well? And it sounds like Keith. Amy, you're just provoking a lot of answers here.
So just a very brief comment, and it goes back to something that Patrice mentioned earlier, but some of what I find heartbreaking in this conversation and learning more and more about the stories is that unfortunately our pain patients are now sharing the burden of stigma that our patients with substance use disorders have been facing for years. And I think not to sort of, we know that stigma exists, and I think when we see people being, kicked off of plans or medications or pharmacists dropping folks, it is because we are misinterpreting that patient and ascribing them to our patient group. So it's an underscore of the need for us to address stigma, and we wholeheartedly believe that how we do that is to teach this country that this is a health condition. We change stigma by explaining addiction as a health condition, and right now only 51% of people understand this as a health condition. The other 49% still think this is a moral failing, and we get that sort of bias that comes. So building empathy and building understanding and compassion for all of our patients, which now we've accidentally brought a whole other patient group into the fold with ours, and I think it makes the need for addressing stigma even more important to make sure that all of our patients get better care than so many of them are finding in a variety of settings.
Thanks, Jessica. Keith?
This is another important point is those of us who are engaged in training of health professionals to teach them what science and as reflected in guidelines can and can't do. Science, it's much better to know the science than fly by the seat of your pants. That's for sure true. But scientific studies are generally about average. What is the average effect in this trial? What is the average effect of this intervention? But people are individuals, and part of your job, and part of the tough thing about being a physician or a psychologist is sometimes you have to say, I know more in this situation, and the average does not apply, and not just give up your autonomy to a guideline. And it's important that a guideline is not a mandate, and the best explanation of how to think about them is in the film Ghostbusters. Sigourney Weaver, the beautiful actress, is possessed by a demon from another dimension. She comes into Bill Murray's apartment, and she tries to seduce him. And he says, I never get sexually involved with a woman who's possessed by a demon from another dimension. That's my firm rule. And she begins removing her clothing, and he says, I said it was a firm rule, but really it's more of a guideline.
That will be permanently referred to as the Ghostbuster moment. Yes.
Thank you.
Yeah.
That was delightful. I want to echo a point made by Dr. Berlin about chronic pain being a condition unto itself or disease unto itself, and the question that you raised, which is how are we going to define serious illness? And I'm essentially going to reference the absence of a language that I know, but which we desperately need in order to do good case management, good coverage decisions, and good research, which is how to tee up and describe complex forms of suffering which are inherently multidimensional. And it is not enough to say that if the MRI shows a little change in the spine, the opioids are definitely indicated. And if it doesn't, then they're not. I mean, we know that's false. Coverage decisions currently, and even my own dialogue, even the way we speak, is often based on, well, this diagnosis is serious illness and this one is not. I'm not here to say that all people should be receiving treatment A or B, but I think we have to recognize right now medical physicians and coverage agents at insurers are both not really great at describing multidimensional forms of suffering. And probably the people I begin to think I want to have in the dialogue are nurses, rehabilitation scholars, and maybe anthropologists to sort of help us think about how to describe complex forms of suffering associated with serious illness so that the future little rule books used by insurers will be somehow more helpful.
Great. Question over here.
Hi, I'm Zach Sager. I'm a psychiatrist and a palliative care physician in Boston. I'm glad that both Jessica and Patrice and Bob mentioned the importance of adverse childhood experiences and speak to the role of trauma. I sit with people who suffer both from psychiatric illnesses and end-of-life distress daily, and I haven't seen anyone either with a serious illness or a substance use disorder who hasn't been traumatized. But so much of the conversation gets fixed on just pills or just opioids or just the substance. And there's a lack of a connection either in talking about adverse childhood experiences. I know when I give a talk to palliative care docs or geriatricians, unless there's someone who's already been to a talk I've given, or there's a nurse or a pediatrician in the room, when I ask who's heard of the adverse childhood experience trial, often no one raises their hands. And so I'm wondering, you are all in positions of power, what we're doing to teach providers trauma-informed care and trauma-informed principles. Thank you.
Dan, is that one for you or? No, anyone else? Okay, right. Okay, Patrice.
Well, clearly it's an issue that we need to continue to elevate because, it's involved in heart disease and diabetes and some of the other chronic diseases that we are a bit more comfortable talking about it. So I think you raise a good point. When I, in my day job as a child psychiatrist, I see that every day, and someone talked about the children who are now being raised by grandparents. And even if there was no trauma in the home, the trauma of being taken away from your home is critical. So we certainly have to elevate the conversation around that. But also we have to then look at policy. So what does that mean for policy? So we have the data now, but how can we incorporate that into our policy regarding early childhood education? So to me, those are the conversations we have to have about what policy should we have for 0 to 3 services in early childhood education. And so we just keep talking about it. And thank you for raising that today.
Thanks. Yes.
Judy Salerno, New York Academy of Medicine. I've been involved with this issue either directly or tangentially since I was part of the VA team that implemented pain as the fifth vital sign, and I'm really tired of being accused of causing this crisis. But in a rather, I've been sitting here all day and running in and out of the room because I've been getting calls, personal situation with a relative who is having a problem with an acute need because of a chronic problem, acute flare-up of a problem, is unable to get the pain medications he needs. And I've been trying to negotiate that long distance and unsuccessfully as of 4 o'clock today. So I'm sitting here thinking rather angrily about what I've heard today, and two thoughts come to mind. One is that somehow we seem to gravitate more to the concept of alleviating suffering than relieving pain. And I don't know what it is that somehow that we're taught that, is there something clinical that doesn't relate to the personal stories about pain that we can relate to as when we talk about suffering, and that maybe we need a new approach to how we talk about this issue. Just a thought, because a lot of us have been banging our heads against the wall on this for decades now with little success, and just as the comment was made, that perhaps we're just thinking about this from one crisis to another and characterizing it differently. Anyway, so that's my thought. And the other thought is that looking across all the different interests that were represented here today, that somehow we can do a better job of building a coalition that can successfully lobby for the sorts of things we need, from whether it be from health professions organizations, training, to Congress. And I'm just angry enough to say, I'm going to get my sign and go protest on Capitol Hill, because there's got to be a better way. We have to make progress more quickly.
But Judy, just so I can clarify, the question is, the area where you think we're making the least progress is on responding to the needs of patients in pain? Is that kind of...
That's one of the many places where...
Okay, but is that what you want to hold your sign about?
Well, I want to hold my sign about that we've made it difficult for patients.
Dan?
Part of what I heard you say is what I hear all the time, which is considering pain as one entity. And Jessica in her presentation, talked about the difference between acute pain, which is a symptom, that usually is, by definition, time limited, and there's some active process for acute pain. And that shouldn't be confused with chronic pain, where there may not be some process that can be ameliorated, that does often associate with suffering in people who have terrible, severe chronic pain. And I think the problem is that people are worried about treating acute pain as if it's chronic pain. That is, that they're somehow going to prescribe something to your relative or whatever that's going to result in addiction or overdose. And, I think we need to be smart about this, right? I mean, if this person has terrible acute pain, giving a day or two of an opioid is not going to result in addiction. It might actually allow them to go to physical therapy or continue going to work or something. But, we shouldn't be giving a 30-day supply for someone who has acute pain, because if the acute pain lasts more than a couple of days, we want to know about it and they should come back. But I think the problem is that we somehow don't differentiate between the acute pain symptom, that means there's something actively going on that needs to be treated for a short period of time, versus the person who's going to be living with chronic pain for the rest of their life, and how do we manage that? They're very different. And the chronic pain issue really is much more like a chronic disease, a multidimensional problem, as opposed to the acute pain. And I've heard a number of stories of people going for joint replacements who don't want any opioids postoperatively. Even in the setting of the hospital, because they're afraid they're going to become addicted. And, I think that's, in my mind, problematic, because they won't be able to benefit from a potential analgesia that will allow them to rehab and get back into, what they were doing before.
Thank you, Dan. That was a very helpful distinction, reminding us of one. So we may have a question or two left, but I'm also mindful of the instructions we got that we're going to end early. But so questions over here? Are you waiting for questions? Yes.
Yeah, not a question as much as a comment of thanks.
Comments accepted.
Okay. So Sherry Lang, Deputy Chief Medical Officer, Centers for Medicare and Medicaid Services. I think this, being with you all today was just a poignant reminder of how our system has been very challenging for the very people that the healthcare system has been intended to serve. And really love the analogy with the three-headed monster. And it actually, we probably have a monster that has more heads than three. So thinking about the opportunities, and what I really love about the panel and about the day is thinking about this as what are the opportunities that each and every one of us can actually take action on. Opportunities that, we are headed towards a value-focused system. We are very mindful and striving for delivering person-centered care that, it needs to include the times where people are not patients. I think given that we have to take a team-based approach because there's just too much information that we need to know to be able to do this well. So one of the opportunities, I think, is for us to think about, and I don't know if Joanne Lynn is still here, but this is something she has brought out years ago, a high-quality plan of care that can be co-designed by clinicians and the people that they serve, patients. So what does a high-quality care plan look like? This is something that I think operationally, at CMS, we're a very operational agency, but believe that there may be elements that could comprise a high-quality care plan. So food for thought. We can discuss it further, but just want to say thank you.
Thanks so much. We're going to have the last question here, Cornell.
How about that?
Yeah, great.
And
Good for
it is
you.
a question, which actually segues from this comment, which is that, Andrew, you had mentioned, the role of value-based care in approaching this. And so what I know about value-based care comes from the oncology care model. And I think, as we think about reimbursing people for providing high-quality care, we have to get that right in defining what it is, right? And how do we do that is my question. So to give you an example of something that I get very frustrated with is that of the many measures that we have to track, right, is pain recorded? Okay, great, yes. Is a plan of care recorded? Okay, great, done. And no one's talking about looking and seeing if that plan of care that's recorded is actually a good plan of care and matches what needs to be done. And how do you do that? And so, I would say while, I want to look at that as a way to now provide more equitable care, I worry that we then too fall into these unintended consequences trap.
Well, thank you for that. And the early efforts at value-based care were looking more at process standards as opposed to outcome standards. Yeah. And for those of us who are in what I would consider the more mature models, we are using outcome-based measures and including patient-reported outcomes, which may be the most important outcome measure of all, or one of the most important ones. And so I think as we mature and get better and get smarter and wiser, we can pay for more outcomes and, as I mentioned earlier, liberate clinicians from checklists and being overmeasured and multiple measures by multiple payers in different ways and allow you to focus more on what you want to do, which is taking great care of your patients and their families. Bob? And after Bob speaks, I'll ask each of you if you want to have a final word or a reflection. It would be great.
At one point this morning, there was some discussion about the fact that people confuse quality with fewer opioid pills being prescribed. And, to me, that measure of how many pills are prescribed is, as you say, a process measure. It's not an outcome measure. Everybody's telling us what's happening to the pills. I want to know what's happening to the people. And ultimately, that's where we need to get if we're going to have value-based care, is what's happening to the people we're working with. Are they being able to achieve the things that they want to achieve as a result of engaging with us? And that's ultimately what the right outcome measure is in my book.
Thanks, Bob. Jessica, final word?
One thing that has sort of struck me is so much of the recommendations and suggestions and priorities from the panel really applies separately to two separate patient populations that we should take care to not, confuse with one another, right? We have individuals with chronic pain and serious illness that need to have individualized care and value-based care, and we have individuals that are struggling with a substance use disorder that need the same things. And I think that there are ways I think that we can collaborate better to make sure that we raise the level of patient outcomes for everyone involved.
Dan?
I think one way to bring in the patient voice is there was this wonderful piece by Dr. Unger, who's faculty at Holy Cross, who has chronic pain, who's on chronic opioids, and he's in the English department. He writes very well. And he wrote a piece in the Journal of General Internal Medicine about his experience coming to his primary care to pick up his refill prescription for his opioid, being asked to leave a urine drug test. And each interaction, at the front desk, being told to go down to the lab, at the lab, being told to leave his backpack outside, don't bring it into the bathroom. The whole experience was well documented by him, and I think we need to hear more of that because, we can kind of try to estimate what the patient experience is around opioids and pain and addiction, but to hear actually from the patient's experience from the minute they walk in the door to the minute they leave, I think addresses the whole issue around stigma and is a perspective that we can't really actually understand until we talk to them.
Thanks, Dan. Patrice?
I would just say
we're going to get you to your plane, too. Okay.
we should all be reminded that there is hope in all phases of this, on the patients who have substance use disorders and the patients who suffer with chronic pain. We just have to make sure that we keep the patient at the center of this and that we make sure that we don't immediately jump to the headline or the top line solution without requiring that there is an evaluation that will come and that there is at least an exploration of potential unintended consequences. But again, there's hope on all sides. There are systems that are working well. There are treatment paradigms that are working well. We just need to make sure that that information is disseminated.
Keith, final words on the dilemma.
Yeah, I was going to echo what Patrice said, that there is very good reason to have hope. When we want to, we can turn back terrible health problems. I mean, I started my career at the time of HIV, and that's been an amazing transformation. If we're willing to work together and willing to invest the resources, we can save many, many lives. We can improve public health. We can improve pain management, and we can reduce addiction at the same time.
I want to thank just a superb panel for all your kind of thoughtful insights and comments and preparation for today. Thank you.